Good morning to you all. This is Dr. Sterino speaking all the way from Brazil. I am an orthodontist in the city of São Paulo. We're 19 million people, the population just in the city alone, not the state of São Paulo. I really want to welcome you all to our webinar today. I'm very flattered and honored that you've chosen to spend the next 45 minutes or so of your Friday morning with me. And the reason I'm here today is to talk to you guys about, I feel like I'm always chasing my own tail, trying to recover from all the side effects of my own mechanics. So I would like to share with you today a little bit of my experience. Everything that you're going to see has been done with passive self-ligation. It's been my choice for the past 10 years or so, a little bit over 10 years, passive self-ligating brackets. And here are 3 basic reasons why I've chosen to change from conventional brackets to PSL. Number 1, it's the only reliable ligation method that I found, and you'll see in a few minutes why. Number 2, it's the only way that I can really guarantee full wire engagement. And number 3, it really allows me to use lighter forces. So here's a picture. I'm very visual, and I do like to read a lot, so I read a lot, everything that I can get my hands on. And this is a paper by Pedersen in 2009, the Angle Orthodontics, and the picture speaks for 1,000 words. You guys can really visualize. If I have a slide, a door that shuts, I can guarantee that my wire stays in that slot, and the wire inside the slot means that the treatment is working. O-rings fall out, and so do ligature wires. So this is a very reliable ligation method, and I can guarantee a full wire engagement. Now, speaking of tooth alignment, here's a paper from Pandis 2007, the AJO. And speaking of faster alignment of severely malaligned teeth, what he found out was that overall there was no difference in the time required to correct mandibular crowding with passive self-ligation and conventional brackets. For moderate crowding, however, irregularity index less than 5, the self-ligating group showed almost 3 times faster correction. My question is, how was this corrected, right? It doesn't say if it was due to flaring, proclination, or stripping. It really doesn't say what method was used for the correction of crowding. Now, greater crowding prolonged the treatment by an additional 20% for each irregularity index unit. So there's no secret. We still need patient compliance, and the harder the case, the more time it's going to take for you to treat it, no matter what you use. Now, there was an increase in intercanine and intermolar widths associated with crowding correction, regardless of bracket group noted. And the self-ligating group showed a statistically greater intermolar width increase than conventional. So please keep this in mind. You can get a greater intermolar width with passive self-ligation. All that play with between the wire and the slot really helps when you're trying to develop arches, and we'll see that in a little while. Also, in alignment-induced increase in the proclination of mandibular incisors was observed for both bracket groups. No significant difference. So no matter what you use, conventional brackets or self-ligation brackets, there's a tendency to procline incisors, mandibular incisors. Another paper by Wahab, 2011, where he compared smart clip, it's another self-ligating bracket, and conventional brackets, and he showed that there's a similar effectiveness for initial mandibular alignment. No difference. And a paper by Miles, 2006, in the Angle Orthodontics, he shows that there's no significant difference of alignment of teeth between self-ligating brackets and conventional brackets after 20 weeks. So the first 20 weeks, about 5 months into treatment, they all behave the same. However, he showed that there's a 0.2 millimeter greater irregularity with passive self-ligation brackets than conventional brackets. Of course there is. The only way we can expect any alignment with self-ligating brackets is when we get into rectangular wires. If you have a good bracket with a good smaller tolerances that really expresses torque and rotation control, you will get full alignment of teeth in the 1425 rectangular wire, not before. Now, Vergeria in 2011 showed that the mandibular incisors were significantly advanced and proclined after treatment with the Damon system, contradicting the lip bumper theory of Damon. So no matter what you do, those lips are not going to hold those mandibular incisors from proclining and flaring. Now here, he showed that the post-treatment incisor inclinations did not differ significantly between the Damon group and the control group. So again, 7 to 8 degrees of incisor proclination with crowding is expected in round wires with any bracket system. Of course, there's no torque control with round wires. Again, here's the question: how do we align teeth without flaring? Well, how do we align teeth, period? You have to obtain space first. How do we obtain space? Well, basically, you can do extractions of premolars, interproximal reduction by uprighting teeth and arch development. Now, when we talk about extractions, to me, that's not an option. I choose never to extract. Interproximal reduction, I don't like that either, and you'll see why. Uprighting teeth, that's a great option, and definitely arch development. I like to call it arch development. Some people call it arch expansion. Now, why don't I extract premolars ever? Here's 7 reasons, right? That makes sense to me. Number 1, there's always going to be an overreaction of those incisors. It's really hard as you're closing spaces, extraction spaces, to maintain the right torque. Normally, you're making that space smaller, right? You've just shrunk both arches. When the incisors touch, and they're not supposed to be touching, when you're doing all of the movements with the mandible, it always comes forward. The mandible always wants to come forward. Incisors touch and create an avoidance pattern. That makes the mandible go back, and it will compress those condyles. There's also a reduction of space for the tongue. It does not eliminate posterior discrepancy. It takes too much time to close spaces. There's a loss of posterior support by a loss of anchorage, so those molars will come forward, and the molars are there to give that vertical dimension and not allow for condyle compression. It eliminates the possibility of the mandible of adapting forward, creating compression again to the TMJ. And last but not least, the most important of all, there's a loss of retrusive guidance. Now, when I look at this picture, and believe me, I've done in the past my share of extractions of premolars, you know what? They look like corpses to me. They really do. So here, from an orthodontic point of view, extractions in this region are functionally critical. And what I see is that nowadays premolars have become supernumerary teeth for orthodontists. I mean, they're the first to be taken out, extracted. Premolars have a very important role in occlusion, and it's the retrusive guidance. Again, look at this case. This patient has lost 8 teeth, 4 premolars and 4 third molars. And guess what? Here's the crowding. The crowding is back. Explain that one to me. I believe the reason that premolars were extracted was, to begin with, was to resolve crowding, and the crowding is back. So it makes no sense to me to extract premolars to resolve something that's bound to come back anyway. So that's not the reason to extract. The reason I don't do interproximal reduction is because I will create a bolt discrepancy. So unless a patient already has a bolt discrepancy, I don't touch that enamel. I don't do interproximal reduction. There are other ways to gain space. You don't need to do stripping. Now here's Dr. Andrews, 1972, his amazing 6 keys to normal occlusion. And one of the keys states that an angulated rectangle occupies more space. True. So let's upright those teeth. That is the most important thing. When he meant by uprighting, he meant by crowns parallel and roots have to be parallel also. So in a case like this, when you look at this case and then you actually look at the ceph, you can see that especially in the lower arch, all those crowns are tipped to the mesial. They're not upright. They're all inclined to the mesial. So the first thing that we have to do is, whenever you see a case like this is how you should finish your case. All the crowns are parallel and all the roots are parallel, not inclined. And then we know that by uprighting teeth, for every 15 degrees of uprighting, you gain 10 millimeters of perimeter in that arch. That's a lot of space. So if I get 10 millimeters in my arch, and I can do a little bit of distalization by extracting third molars, I don't need extractions at all. So here's one more reason why you don't need to extract premolars, where you shouldn't. And you can I usually do this uprighting by using either TADs in the buccal shelf, mini screws, or tip back bends. But that's another webinar. Now, speaking of arch development, if we look at all malocclusions, class 1, class 2, or class 3s, and you actually play with those plaster models, normally the upper arches are constricted. There's a low tongue posture. And we know that 80% of arch development is uprighting teeth, because they're usually tipped to the lingual, and 20% is bone remodeling. It's very necessary for a good arch coordination, and allows for a correct intercuspation, and that will give you functional occlusion and stability to your treatment. So let's look at this. Again, I'm very visual. This is a great picture that I got out of a museum in Poland, and it's an arch. And if you look at it, it's what we have in our mouths. It's what kind of arch is it?
I have a piece of rope. If I hold it between my hands, it forms a curve. This is called a catenary curve, and it is not a parabola. The word catenary is derived from the Latin for chain, because it's the shape formed from any chain or rope hanging freely under its own weight over A. The curve changes as the distance between the two ends and the length of the chain changes. But if the catenary is the shape of a rope or a chain that minimizes forces in tension, then by turning this upside down, we form an arch which minimizes the forces in compression. And it's actually the strongest kind of arch, strong enough to support its own weight.
So if we look in their mouths, what do we have? We have a catenary or a catenary arch. No matter where, an arch will behave like an arch. It's the strongest kind of arch. And now we've seen very graphically that you can flatten that curve just by changing the distance at the end of the catenary arch, or the catenary arch. And not only that, there's a thrust line that runs within that arch. And if that line is preserved, there's stability. If you take away premolars, if you extract them, you just destroy that thrust line and there's no stability. Those arches will collapse with time. Here's the university I teach in São Paulo. It's called USP University of São Paulo, where I have, with these two amazing professors, a mini residency course. To the right is the head of the department, Dr. João Paiva, and to the left is Dr. José Rino Neto. And these are my amazing students. And what I'm about to show you is a few of their cases. And I figured if it works for me in my office, it has to be reproducible. So it has to work anywhere else. Now, how do we prevent flaring and round tripping? Of course, obtaining space first. Number 2, very important, extracting third molars. You have to resolve the posterior discrepancy, not after treatment, before treatment. We need that space. You have to bypass crowded teeth. And how do I do that? Extra light open coil springs. And you have to measure it. Okay, it's not a bracket or a bracket and a half. It's 50 grams. Guess what? Coil springs have no power to open space. They will guide where the spaces have to be. They have the power to procline or protrude or flare everything. No power of opening spaces. Arch development does. Now, disarticulation on every patient. And I don't disarticulate my patients by eyeballing. It shouldn't be done randomly. It's to give them back their ideal vertical dimension. There are many ways of doing it. The way that I choose to do is by finding each patient's ideal Shimbashi's number. That's where their muscles are at their best genetics. They're not extended, they're not contracted. And that's one of the ways to really make sure that those devilish deep overbites are going to be corrected, and you're going to be able to maintain that vertical dimension. You need to give it posterior support by intercuspidating those molars so you don't get compression to the condyles. Now I use expended thermal activated NiTi wires, really broad wires in the posterior. The anterior curvature remains the same, but the posterior, they're broader. No matter if it's a class 1 or class 2 or class 3 malocclusion, and if there's crowding in the lower arch, I will start with class 3 through the bite elastics and crossbite elastics, and I'll show you why in a little while. You can always use Mulligan's overlay, and I'll show you how, or you can do unmasked distalization with TADs, infrazygomatic crest TADs, or buccal shelves. Here's just an example of a case, and you look at this case, and there's mild crowding, there's a posterior crossbite. So here we start with early light short elastics, class 3, from upper 5s to lower 3s, and then crossbite elastics from upper 5 to upper 6s to lower 6s. It's an inverted triangle. Please make sure to measure these forces. You don't want these elastics to be greater than 75 grams. Here's your best friend. To the right, you have a gauge. I use the Corex. Very, very precise. And 75 grams, no more. You don't want those lower molars to start rolling in. And the reason that I use crossbite elastics is because I don't want any side effects of my class 3 elastics. I'm using class 3 elastics to upright canines. In this case, I'm pulling off of the buys because the canines are outside the arch. So the crossbite elastics here are to keep those molars in place. So there's not going to be any side effects from my class 3 elastics at the same time that it's developing the upper arch. So here we have the extra light. Please don't use medium, or it has to be extra light coil springs. And the measurement, you bypass all crowded teeth, no more than 50 grams. You can look at those coil springs and you see that they're not compressed at all. They're very, very light compression. Bypass every single crowded teeth. Here's another picture so you can see. And you can see that the third molars have been extracted. You can see that there's a stitch on the right. So extraction. As I bond my patients, if they don't do extraction prior to strep up, first wire, they go for extractions, and we start our treatment without third molars. I need to resolve posterior discrepancy. Here's just a little diagram so you understand. For the upper arch, you can use lingual buttons, but I prefer to use Kaplan hooks, and you'll see Kaplan hooks in a little while. So it's through the bite, short class 3 elastics from upper 5 to lower 3s, and crossbite elastics, upper 6s to upper 5s to lower 6s. Here's 10 weeks into treatment, and still the same 014 NiTi wire, thermal activated. We can see that there's space for that canine, and I've incorporated that one. The other lower canines are in again. If there's no space, I don't pull from a distance. Why? Because if there's no space, there's going to be flaring. The adjacent teeth are going to rotate and flare. This is an 014 wire, very, very light. Here's 20 weeks, still the same wire. No, we don't incorporate. Actually, you know what? Teeth have proprioceptors. Give them space and they come in. So you don't have to pull them from a distance. Just give them space and you'll see how they come into their places. Here's 30 weeks, and finally we have space for the upper lateral. Look that we've incorporated it. Please make sure that those wires do not deflect more than 1 millimeter. Anything less is perfect. More than 1 millimeter of a deflection, it's going to cause you side effects. You're going to get rotation and tipping of adjacent teeth. So don't go grab them unless there's space. And as you see that the upper arch develops, you see that the lower arch follows. If you don't develop the upper arch, there's not going to be space in the lower arch. So we've incorporated both laterals. This is 50 weeks, and it's the first time that we're changing wires. So there's no haste to change wires. Let it cook. 50 weeks, and finally we go into 1425 NiTi wires. Now you can observe this is the first time that they're going to start to align. So you cannot expect teeth to align before a 1425 NiTi wire on a passive self-ligation bracket. It just won't happen. So here's 50 weeks. Here's your case. Very little to do here. A little bit more of upper arch development. We're going to correct that midline, but basically no flaring at all. No proclination. No flaring, no proclination. So that's halfway. Everybody that has flared teeth before knows how hard it is to upright them. It will take you an extra 8 to 10 months of treatment. 8 to 10 months of treatment. So here's another case, also from my students, and you can see the malocclusion starts to get worse. There's more crowding. Again, we start with the same setup, disarticulation, early short class 3 elastics from upper 5s to lower 3s. We have crossbite elastics, upper 5 to upper 6s to lower 6s. Again, 75 grams. All these forces are measured. Please take your time. This could really save your case. Okay? It takes 2 seconds to measure forces. Don't grab any elastics and put them on. Okay? Different distances will give you greater or lower forces. Different crown lengths and crown widths, so please measure them. Here's, again, extra light open coil spring, activated no more than 50 grams. Here's what the patient looks like with the elastics on. Here's bonding, initial bonding. Here there's a picture of the Kaplan hooks that I really like. Not only can you place them more gingival, but they're closer to the center of resistance of the tooth, and elastics will pop, but they won't come off the Kaplan hooks as easily as they come off a lingual button. So bonding, this is 10 weeks into treatment. You can see that we're gaining space. 20 weeks. We finally go grab a canine. There's enough space for that, upper canine. 14, this is 30 weeks. And here, look at the deflection of the wire. No more than 1 millimeter. There's not enough space yet, so don't grab that lateral. So 30 weeks, this is what we have. Finally, we go into 40 weeks, and that's when we grab the upper lateral. 018 wires. This is 2 weeks before 1 year, 50 weeks. And this is when we change our first wire. This is 018 night tie. And then finally we go to 1425 in 60 weeks. So here what it looks like after 60 weeks. Not much left to do here on this malocclusion. Still, we have to finish leveling that curve of space. So as you can see here, you keep the through the bite class 3 elastics and cross bite elastics because it's not corrected yet. We go into a 1425, and this is when you expect to start seeing alignment, or to actually really align the teeth on a PSL bracket. So here's from bonding to 1425 night tie wires, 60 weeks. There is no proclination, and there is absolutely no flaring of the teeth. None whatsoever. Remember, there is no way to express torque on a 1425 rectangular wire. So I haven't even started torquing these teeth because there's no need to. I don't have to recover from my own mechanics. Here's another malocclusion, and it's getting worse again. Bypass crowding. And in this case, it's funny because the student looked and thought that it wasn't that constricted, so no lingual buttons needed, no crossbite elastics, so he decided to run elastics on the buccal side. So here we have strap up, and that coil spring is activated only 50 grams. However, elastics are run on the buccal and disarticulation. Let's see what happens. So this is what it looks like. This is bonding. This is 10 weeks. This is 20 weeks. And guess what? Look at that. We have an open bite starting to happen because, of course, if you run elastics on the buccal, no matter how light they are, they're going to prevent those arches from expanding all that they should. Everything is going to procline and everything is going to flare. And now you have an open bite starting to happen. And guess what? Everything's flared. Now I have to recover. Okay? And something else. There's a tongue thrust. So now what do I need that I didn't have before? I need tongue tamers, or tongue spurs. So we get the spurs going, we get Kaplan hooks going, we get early light class 3 through the bite elastics and cross bite elastics. Now you can see that here's 60 weeks. First, this is when we incorporate that lower cuspid because we finally have space, no more than 1 millimeter of deflection of that wire. And you can see as you develop the upper arch, then the lower arch will follow. So here's bonding, 20 weeks open bite, disaster happened, 40 weeks recovery. You can see the posterior part of the upper arch developing. This is 60 weeks into treatment. 70 weeks, this is when I first changed that lower wire to 0.8 nights high. And 80 weeks, that's a 1425 rectangular wire. And you can see that, look, it's recovered. There is no more flaring, no protrusion, and this is only a 1425 night high wire. This is when we start aligning teeth. I haven't even put any torque in, and a 1425 will not torque those teeth. There's no torque expression. So this is anterior torque control, absolute control by posterior arch expansion. Here we have where we lost control, and here's how we recovered. Upper teeth are upright, lower teeth are upright, and now we're just going to do our class 2 mechanics. Here's another malocclusion. Like I said, they start getting worse. Again, we start with extra light open coil springs, same setup, Kaplan hooks, class 3 short elastics through the bite, crossbite elastics. So we have initial bonding, 10 weeks, 20 weeks, 30 weeks, 40 weeks, and this patient was really a sweet girl, very compliant. Guess what? 50 weeks, and we remain in the same 014 wires. This is a little bit less than a year, and if you look at it, midlines are coinciding. And she was so compliant that her teeth, the upper teeth started to flare. No problem. You still have disarticulation. Guess what? All you have to do is run elastics on the buccal side. They will tip to the lingual easily in 10 weeks, and it's recovered. You can observe that midlines are coinciding, and there was absolutely no flaring and no proclination of the upper incisors or lower incisors for that matter. Again, now there's something else that I like to use. This was described by Dr. Mulligan in 1980. It's called the Mulligan overlay, and it's lovely. You can use it the way that Dr. Mulligan described, directly tied to the wire or to the central incisors, upper incisors, or if you want to keep the torque control, you can use a double tube. Let's see how that is used. This is the Mulligan overlay, and this is how it works. If the desired side effect is uprighting of the central incisors, watch this. As you get transverse development, you will get uprighting of the incisors. So I use it on very few cases, tied to the wire, and I'll show you. This is a very extreme class 2 case. This is how she came in. Everything's proclined, protruded, and flared on the upper arch, very constricted on the posterior. So I asked for the extraction of upper baby cuspids, and setup is here. This is strap up. This is the only time that I use baby eyelets also, because I need to hook up that Mulligan overlay. I'd rather do a 2x4 without baby eyelets. But here's an 012 night high wire, and you can see that it's very light. And the reason I grabbed that lateral is because I had enough space, so I'm not going to have any side effects by deflecting that arch that much. Tongue tamers at the bottom. I want to remind that tongue to go up. You can see that there's no space at the bottom and no space on the upper arch. This is what she looks like. Again, so she leaves the office like this. You can use, this is how Dr. Mulligan described it, by using 2 hooks on each side. This is 5 weeks, and guess what? With these young patients with Mulligan, I suggest you see them every 5 weeks. I see my patients either every 5 weeks or every 10 weeks. So here's a 5-week interval, and here's a 10-week interval. And this is when the Mulligan comes off. So very quick, works beautifully. This is, and I just do a regular 2x4. This is 20 weeks. She's just now, this last week, an 1825 night high wire. Broad wire, very expanded in the posterior, so there's more than enough space on the upper arch. Now all I have to do is treat the class 2. That's a piece of cake. So this is what the little girl looks like. This is the day she came in. This is the day she got her Mulligan off. This is another patient, adult patient. She had 4 buys extracted a long time ago. Very difficult case. She comes in. She's a perio patient, so using very light forces. Here we have the original setup, crossbite elastics, class 3 elastics. Develop a little bit of the posterior, and then she gets a short mulligan. And by short mulligan, I mean very short mulligan, because I really needed to develop more of the anterior part of the arch and then upright those incisors. So this is what I get after 10 weeks. So 10 weeks with mulligan, I go into a 14-25, and this is the difference. It only took 10 weeks to get here. Very good result. Here, fuller smile. Now we're going to just treat her. This is another case, an adult, and this is an interesting one because the only time I change wires very fast is if I want to flare teeth, and in this case was very beneficial. I really wanted to flare those upper incisors. So very difficult case, constricted upper arch, constricted lower arch. The midlines are deviated, functional shift, a major curvus P in the lower arch. So disarticulation, I change wires very fast. This is 018. This is in 25 weeks. I go into my 18-by-25 night high wire, and this is the first time I use a mulligan. And the mulligan here, I am using 3 double tubes. Why? Because I don't want to lose the torque control in my incisors. I don't want them to dump lingually. So here I have 3 double tubes, and you can see 2 in the posterior, and what you see there is a little bit of composite so they don't slide off and they don't poke the patient. So this is, you can see that there's no overjet. Then I get a major overjet as I pull my little catenary arch on the posterior, so I flatten the anterior curve. Here you can see that the upper arch has developed a little bit in the posterior. I have complete torque control of the anterior teeth with a double tube. Now I went from that to a shorter version of my mulligan, and now it's tied to the wire because I did get a little bit of too much flaring with the other one, so I'm going to recover from it. You can see the midlines are almost coinciding. So here's a shorter version. I chose to use the same mulligan I had before. I just cut it shorter and just bended 2 hooks to it. So here's beginning, longer mulligan, shorter mulligan, and this is when I finally get the arch shape that I need to correct the class 2 to allow for that mandible to come forward. I have spacing on the upper teeth that I'm going to use to correct that little peg lateral right there, actually both laterals, so I'm going to close those spaces by adding composite to those teeth. So this is it. This is how we go from this arch shape to that one, and that's the most important thing for any treatment, is to have enough space to coordinate those arches. Now, what do? Midlines are coinciding. I put my mulligan overlay on the bottom teeth. You can use the mulligan either on top or bottom. Now what I'm going to do is just finish treating the class 2, and I have a cant of the occlusal plane that I need to correct. This is just regular class 2 mechanics. Here's another one, case yet from my mini residency students, and even though it looks like a surgical case, believe me, it's not. And what you need here is strategic and patience, right? Arch development takes time. So here again, we have extra light open close springs, no more than 50 grams, Kaplan hooks, the same setup, disarticulation, and class 3 short light elastics, crossbite elastics, measured bypass all crowded teeth. So bonding 10 weeks, 20 weeks, 30 weeks. Now we incorporate a little bit of a short overlay. Again, this is 40 weeks. You can see the upper arch is already developing. We finally get spaces for one of the laterals. The other laterals, we don't grab it yet. Now we go from a upper mulligan to a lower mulligan, as you can see. Now we went back to the longer mulligan, so you can go back and forth. If you feel like you need more development on the posterior, you put the mulligan a little further back. You can do it a little bit shorter and to the front. You can do an asymmetrical mulligan. It depends on what you need. Now, I think I have all your attention again. Be careful with this. this is what I really want to avoid at all costs. It's the balloon effect. What does it mean? You have an air balloon. If you squeeze it, everything goes forward, right? So I don't want the balloon effect. Every time you disarticulate a patient and you have elastics that run on the buccal side, guess what? It's going to constrict those arches because there's an extrusion component to those elastics. And every time we make a step down band, what happens? The teeth tip to the lingual. So run through the bite elastics. Watch this case. Also from my residents, this is another professor. It wasn't one of ours, but we tried to recover from it. So here we have, what is wrong with this picture? A lot of things. Not only do we have, the student bypassed the crowding, except for the upper lateral. Look, there's not enough space, and they already ran the wire through it, like the upper lateral, I mean. And then those coil springs that are in there, as you can see, they bypass one crowded tooth. That's it. So if you look at this picture, what is wrong with it? Look at the coil springs. This one is certainly not activated, just 50 grams. This is a bracket or a bracket and a half. That's what the student was told. So here's another coil spring, and the activation of this one is also greater than 50 grams. You can see how compressed it is. I mean, all three of them are very, very activated. What's going to happen? This is 10 weeks. Guess what? The lower lateral has been incorporated, and there's certainly not enough space for that. Elastics are being run on the buccal again, still, I mean. And the upper lateral was also tied from afar, and there's no space for it. Everything is flared already. There's an open bite starting to happen, and here it is, 10 weeks. Look how flared it is. And what you think you gained space by activating those coil springs, you didn't. You just protruded everything and flared. Now you have two things to recover from. Number one, the lack of space. And number two, the flaring and protrusion. Not only that, look at those third molars still in the mouth. There is no way to develop the posterior section of that arch and to do the mechanics that is from anterior to posterior with those third molars in there. They got to go. Extractions first. Here's 20 weeks. Third molars have been extracted. Everything is flared. Now we have to recover from it. And they keep tying the upper lateral. Look at that. 40 weeks. Again, case is lost. We have to recover. So we're starting over. We just added, 8 months to that treatment. We've lost 40 weeks. And now we have to recover. So this is beginning, and this is where we're at after 40 weeks. Oof, even if you run rainbow elastics to try to detorque those upper center incisors, you still have those short elastics on the buccal side. Look how constricted that posterior segment of the upper arch is. Look at that. Look at the amount of flaring. Now here finally we get tongue tamers going to get that tongue out of there. Kaplan hooks. In this case, it's really hard to run those crossbite elastics because that upper bicuspid is out of the arch. So we opted for a mulligan, and I'll show you in a minute. This is a neat little trick, and I'm going to show you in a little while. My students call it the Sterino leash. I'm sure a lot of you use it already. So for the ones that don't use it, I'm going to show you what a Sterino leash is. Here we have a mulligan running on the posterior a little bit. And this is 8 months later. We have a shorter mulligan, and this is a 1425 night tie wire. Remember, we have not started to torque those teeth yet. Look how uprighted those incisors are. So there's a way to recover from the flaring, my friends. So this is good news for you guys that, like me, have flared teeth before. So this is what it looks like after 8 months as you expand the upper arch and wear those class 3 elastics and the Sterino leash. Look at the detorquing or the uprighting of lower incisors also, right? No elastics were run on the anterior. I don't like to run rainbow elastics on anterior teeth. They have to be very light and maybe just night wear because I don't like to extrude those incisors. That's the least stable movement you can make, especially for closing open bites. This is one of my cases. She came to, speaking of open bites, I'm her third retreatment. As you can see, they've tried to close her open bite by extruding incisors. Like I said, it's the least stable movement. Bite is opening again just 6 months after she finished her second treatment. So here we have strep update, disarticulation, early light elastics, cross bite elastics, short class 3 elastics, and you can see that her upper 3 to 3 are flared. They're all flared. So when I finally get into 1425 night tie wires, remember it's a very flexible wire. So every time you get a flexible wire and you compress the anterior curvature, it expands on the posterior. I have a lot of play between the bracket slot and the slide, the door, and the wires, which is very convenient at this stage. So what I do is just get a piece of power chain, regular power chain, and I use the short one for the upper arch. And here I run it from upper 4 to upper 4. And what I do is I put it on the bracket under the wire, and I run, so if I have 8 teeth, I run 7 eyelets on the incisal edge of those teeth. Why? Because it's going to catch a couple sooner before you get into posted wires or before you get into any other heavier wires. You can catch a couple on a 1425 night tie wire. And this power chain not only does that by detorquing, by rolling them in, but it also prevents extrusion. Remember, every time you upright teeth, the side effect is extrusion. This power chain will not intrude your incisors, but it will upright them bodily, preventing extrusion. So it's a neat little trick. Here you can see how it goes. So from 4 to 4, you can run it from 3 to 3. You can run it from 4 to 4. Remember to run it under the wire because I don't like friction, right? I use PSL to minimize friction. So under the wire, stick your wire in there, run it over the incisal edge of the other teeth. And guess what? Only 10 weeks, teeth are upright. Be careful because they will keep uprighting, right? You don't want them to tip to the lingual. So call them back every 5 or 10 weeks and take a look. Now, here's a very interesting case because she's an open bite class 3 case, apparently. And it turns out those are premature contacts, and she's actually a bad class 2 case. So now all I had to do was do my class 2 mechanics. Here's 25 weeks on a 1425 night tie wire. You see that leash running up there. She looks a lot better. Everything that was flared is upright. And I managed to finish the case like this. And you can see that upper teeth are upright, lower teeth are upright. Not only that, she's got about 1 millimeter to do all that function with her mandible, protrusion, retrusion, lateral movements. I don't like to, incisors shouldn't touch, remember, never. So here, when she came in, and this is how I finished her. Here's another case that I also lost control of the case. I thought, I was doing the right treatment at the time. I don't anymore. So class 2, overbite, young boy. What did I do? What I used to do at the time, a twin block. He was very compliant, wore that twin block very beautifully. So after 11 months, hey, guess what? I look at him and say, wow, profile looks better. He's treated. Not even close. This is to the left is the beginning ceph. To the right, this is what I did. I managed to flare low incisors like crazy. The curvus P is not leveled yet. So what do I do now? I have to recover from this because this is relapse waiting to happen. And as I probably, most likely am going to level that curvus P, I'm going to flare more of those center incisors. And I managed to what? To upright too much those upper incisors. So what do I do here? I have to recover. How do you recover? Now, for my class 2 patients, I run long class 3 elastics. If they have constricted upper arches, I run them through the bite. In this case, that boy didn't need it, so I ran it on the buccal. So long class 3 elastics from upper 6s to lower 3s and the Sterino leash. But for the lower arch, I run a continuous. So I have 6 teeth from lower 3 to 3. So I just cut 5 little eyelets under the wire on the bracket of the 3 over the incisal edge of the incisors to the other 3. Remember, the effect is not only uprighting but preventing extrusion. It's a neat little trick, just a power chain. There you go. So watch out because they will upright. And here's after 20 weeks. So I finally recovered the overjet that I needed to treat the boy. And this is how I managed to finish his case after my class 2 mechanics. Doesn't look that bad, huh? And lower incisors that I totally flared are uprighted. Upper incisors are at a pleasing torque. Also, for my younger patients, I leave about 2 millimeters of space there because he still has residual growth and he needs to make all those movements with the mandible. Very functional occlusion. This is how I managed to finish him. Funky little lip, nice smile, beginning and end. By doing the disarticulation on his true vertical dimension, I'm able to treat the overbite, and this is going to be stable because look at that. All the teeth are uprighted. The crowns are parallel, roots are parallel. Molars give support to the occlusion. That bite will not deepen again if you manage to intercuspate this patient very well. So here's where I lost the case to the left, and this is how I managed to finish him. Change that occlusal plane. Class 2 is treated. Stable occlusion. Again, so how do we maintain anterior torque control, or we prevent flaring and round tripping? Please extract third molars. Resolve posterior discrepancy at the beginning of treatment. Stay in first round wires as long as you need. 014, 012s, no rush. Let it cook. Bypass crowded teeth with extra light open coil spring. Measure those forces no more than 50 grams. Use those from the beginning expended thermal activated night-tie broad wires. Disarticulate every patient on their ideal vertical dimension. It's very important. Remember, disarticulation shouldn't be done randomly. There's a reason for disarticulating patients. No matter what malocclusion they have, class 3 vector elastics through the bite and crossbite elastics, early elastics. And guess what? Neat little trick, 3-3 incisal power chain or 4-4. Use that as Sterino leash, never on round wires, preferably on 1425 night-tie wires. Thank you very much for spending your morning with me, or a part of the morning with me. Here's my email. If you have any questions, send me an email. You can find me on Facebook also. If I do take a little longer to respond, is because I am on a plane flying somewhere, but I'll get back to you as soon as possible. Thank you.